This conference will now be recorded.
Great.
All righty.
Well,
welcome. Thank you guys. I'm Alicia Torres, Title X Program Manager with the Nevada Primary Care Association, and today's webinar is being presented by Lisa Seamus with the Family Planning National Training Center on integrating, and she'll be discussing integrating Title X family planning services into the primary care setting. And without further ado, I will let Lisa introduce herself and get started.
Great. Thank you so much. And thanks for inviting me here to talk about the integration of Title X into primary care settings today. As a little bit of background, first of all, can you all hear me okay?
I can.
Okay, great. Great. As a little bit of a background as to who I am, I currently work for John Snow, Inc., which is commonly referred to as JSI. They're a public health consulting firm, and we have 7 offices domestically and then a number of international offices with, I think like 2,000 employees. And we hold a lot of federal contracts around training and technical assistance, including the Family Planning National Training Center contract. I've been in this role as a consultant and content area expert, I guess, for almost exactly 2 years now. And before coming to JSI to be in this role, I was the DOPE, or the Director of Program Evaluation, for the Arizona Family Health Partnership, which is the Title X grantee in Arizona. And while I was at the Title X grantee, I had the opportunity to work through the process of onboarding a number of federally qualified health centers to receiving Title X services. And it's something that I'm really super passionate about doing. I know that it comes with a number of challenges. And so having gone through some of them myself, I am more than happy to share any experience that I have, any areas where I can answer questions or be of help, because I do know what a hard road it can be, and also what a gratifying and rewarding experience it can be. So before we jump into today's session, I just wanted to kind of get a quick pulse in the room. I know we already went and introduced ourselves with our names and our positions, but I also wanted to ask each one of you, what one thing, if you walk out of today's meeting with one little nugget, one piece, has there been something that you've been thinking about that you would like the answer to on today's session? So maybe we can start with Andrea.
Sure. I think my biggest hiccup is more how we get this integrated into a workflow that's already running, right? Like, how do we simplify workflow, and how have other FQHCs found success with integrating Title X into their workflow, and maybe some strategies that they did to accomplish that?
Great. I think we have a couple of things on the slides that might help you address that concern, and then maybe as we're talking about those, we can take a deeper dive into than what I took on the slides. And Kirsten.
For me, I think right now a big piece of this is going to be how we incorporate the billing. So I think exactly kind of what Andrea said, and then if we could incorporate a billing component here on how all of this works together would be very helpful.
Great. And for that, there are resources on the FPNCC website, so we'll remember to circle back and talk about some of those resources.
Thank you.
And Annette, sure, Annette.
Those questions were very well articulated, and that covers it for me. Thank you.
Great. And how about Olivia?
I kind of agree with Andrea. It's what I keep thinking about is how we are going to integrate this new program into an already existing workflow, and just kind of how we're going to fit it into what we're already doing without necessarily interrupting our providers as well as patient care.
Great. Those are very, very valid concerns, and many in FQHC have gone before you to figure these things out. So hopefully we can rely on some of the lessons that they've learned and some of the systems that they put into place. All right, so having said all that, I wanted to just kind of start off with talking about what the objectives were when we set up this training initially. And basically, we just wanted to make sure that we're all on kind of a set playing field in terms of defining integration of Title X into primary care, because it can mean different things to different people. I'd like you all to be able to identify at least one benefit to integrating family planning into your primary care services by the end of today's session, and identify at least one implementation strategy that you can bring back to your site to advance that integration, hopefully related to those things that you said here are the items that have been on your mind and been challenging for you. So how many of you are familiar with the CDC and OPA, what we call the QFP, or the Providing Quality Family Planning Services? All right, so this would be your number one go-to source for figuring out how some of that implementation is going to work. This is a document the CDC and the Office for Population Affairs jointly authored in 2014. It took them a very, very long time in the process. They had multiple work groups that came from all different aspects of healthcare. And their main goal was that they really wanted to take the Title X work that had been done and make it so that it was accessible to a broader audience of providers that provide primary care STD services, as well as the traditional family planning providers. So again, it's called Providing Quality Family Planning Services, but as you move around the Title X space, you're going to hear this referred to as the QFP. And it's sort of the Bible of how to provide those quality family planning services in our world. The recommendations outline how the family planning services can be provided by defining the core set of family planning services for women and men, and describing how to provide those contraceptive and other clinical services, describing how to serve adolescents, and how to perform quality improvement. So, what are the core family planning services? According to the QFP, and again, Title X world, we really think about 6 different core family planning services, which are that purple, darker purple inner circle, and I know that the slide is kind of small, but basically the core family planning services are providing contraception to help women and men plan and space births, prevent unintended pregnancies, and reduce the number of abortions, offering pregnancy testing and counseling, helping clients who want to conceive, providing basic infertility services, providing preconception health services to improve infant and maternal outcomes and improve women's and men's health, and providing STD screening and treatment services to prevent tubal infertility and improve the health of women, men, and infants. So the related services are in that second circle, the white circle, and these are things that we used to kind of think of went hand in hand with family planning and had to be included in order for it to be a family planning visit. But we really discourage folks from making too tight of a connection, and encourage people to understand that you can provide family planning services, those 6 core services, and that the middle circle are really related and beneficial to reproductive health and loosely linked to family planning services. And they're absolutely appropriate to deliver in the context of family planning visits, but they don't contribute directly to achieving or preventing pregnancy, which is what family planning services is, what the core family planning services are, right? So, and then in the outer lighter purple services, you'll see other preventive health services, such as the ones that you all provide in your primary care settings, that don't have a direct link to family planning, but are generally considered, and that aren't generally considered part of your family planning program, but that are, great services that need to be provided by folks like you. So the scope of your family planning program is determined by the agreement that you have with the Nevada PCA. So in looking at this picture, if you have any questions about what the definition of family planning is for your site, you'll want to go back to your contract and or talk to the folks at the PCA to, find out what their expectation is of what your family planning scope of work would be. Are there any questions about those core services? Are all of you providing those 6 core services?
Yes, we are at CSA.
Yes. We're
Great.
doing the same at Hope.
Excellent. All right. So
I'm
get to that
curious,
basic.
this is Andrea. I had to wrap up with a volunteer for a moment, and I might have missed this, but is there a place where I can download these slides? Oh,
We'll have
Alicia
them
just said she'll
available
email them
after.
Okay.
Yeah.
Yeah.
All
right, thank you.
And I don't think I put a link to the QFP in the slide, so we should probably provide you with that as well, because it sounds like a lot of you have not had the opportunity to read the QFPs, and I would really encourage you to look at them to kind of get a feel for, for those services.
Yeah, this is Alicia. Actually, everybody should have the QFP in the binders that I made for you, along with some slides on integrating the QFP. And we also have an archived webinar on our website that Jackie Witt did a couple months ago. But if anyone else, if you need the link or anything like that, we'll make sure to get it out to everybody.
Thank you. All right. So moving on to the clinical pathway. That's your cue. Moving on to the clinical pathway. And we can't hear you. That's okay. All right. So to address Andrea's question, and I believe that Annette and Olivia also had questions around this in terms of, you already have workflows. And so how do you integrate this with as little disruption to your currently existing workflows as possible? And one of the diagrams that is on the Family Planning National Training Center's website is this clinical pathway. So we've defined family planning, and now we're going to look at how we integrate those family planning services into the primary care workflow. And in what I call fully integrated clinic, many of the visits will be guided by the principles of this clinical pathway. And again, we designed this based on those recommendations in the QFP. So many agencies use this tool to encourage full integration, and I'll talk a little bit later about what I mean when I talk about the difference between full integration and integration. But this demonstrates how at each visit, you can address both the need for family planning services and the need for the primary care services. So after an initial determination of the reason for the visit is made, the clinician can generally go down one of 2 paths, right? If the client is there for a reason that's not related to preventing or achieving pregnancy, the clinician would first address all of the client's needs for the reason that they came in for the visit, such as, acute care or chronic disease management, other preventive services. And then following down the right side of the pathway, after the clinician addresses those issues, then the clinician can also touch base with the client to see if there's a need for any of the family planning services. So if the client does have a need for one of the family planning services, then the clinician should also provide the accompanying STD and preconception health services per the clinical recommendations. So in looking at this, it's one thing to have an understanding of the clinical pathways and how the workflow might work, but ensuring that clinical staff, including clinicians, medical assistants, health educators, and others who might be counseling clients are comfortable and feel confident in having conversations that are needed to implement the clinical pathways is a whole nother story. And later I'll share a lot of resources with you to help you and your staff gain that comfort. So does this clinical pathways make sense to people?
It makes sense to me, but we're an FQHC, and we have 15-minute office visits, and some are half an hour. So our clinician's time frame is very, very limited. So what I think we're going to be most interested in is how do we do this and still and not hold our provider and the medical team back from moving on to the next patient, which is the goal, that we don't have our patients in the waiting room for longer than they need to be. We don't clog things up.
Yeah, that is an excellent point. So some of the things that people have done, so there's some clinic flow and clinic efficiency tools that are on the FPMTC website that we can take a look at. That's one thing. And then looking at the staffing of who's providing the family planning services can be another way of addressing some of it. So, I have a slide later that talks a little bit about sort of making sure that everyone is working to the top of their scope or the top of their license, so that, if the MAs can be trained, assuming you use MAs or the equivalent of medical assistants, if they can be trained to do the counseling and education pieces, to take that burden off of the clinician. And so that's one way. And then also maybe looking at the scheduling appointments and seeing if there needs to be some modifications can be another thing. Another thing I'll talk about a little bit later is also setting up your exam rooms for success in terms of making sure that all the supplies that you need for family planning are in there, so that people aren't sort of scrambling around and trying to find the supplies that they need, which could create, more of a time burden, right? So there are little tips.
I understand. So what you're saying then is integration into the clinical or into the setting really can take different forms, and it could be that we do not that we just determine that these services are needed and have the patient come back, and that the expectation isn't that we always turn the visit into it can be a Title 10 visit, but it doesn't necessarily, everything is not done in the same appointment.
Well, that's one way of doing it. The strong preference is to have it integrated into that visit. And I'll talk a little bit about that in a moment. So the tips and tricks that I was talking about were tips and tricks to try and ensure that you're reducing any kind of unnecessary time delays by, again, setting up the exam room so that it has everything that you would need for a family planning visit, or taking the burden off of the clinician for the counseling and education piece by making sure that your MAs or other support staff for that visit can do the counseling and education piece. And then the clinician can confirm the client's method of choice. So that sort of thing.
Yeah, that's the part that makes me nervous.
Yeah.
Getting it all done in that visit. And as you said, because that MA, once that visit is complete, the MA is on to taking vitals and rooming the next patient. So that'll be one of our challenges.
So it sounds like you might need to look at some staffing considerations. And, I don't know how your budget was developed, but one thing that I recommend when people are looking at their budgets is to ensure, with some funding sources, and you probably already know this about Title 10, some funding sources you can only pay for certain things, but Title 10 is generally very flexible in terms of providing funding for staffing and for other things that, for example, your Medicaid reimbursement might not pay for, right? So maybe encouraging taking a look at that to see if you can pad those visits by another couple of minutes, especially if you know that it's going to be a dual visit, which you don't always going into it, right?
Right.
But definitely taking a look at how you're using the family planning grant funds to be able to support success in that manner.
Thank you.
Sure.
This is Andrea, and I agree with that's going to be one of our bigger challenges, because we know that for our populations, and we're also an FQHC and a patient-centered medical home that evolved out of an HIV clinic, a lot of our patients come in with so many different complaints or issues, and we often have to integrate case management or behavioral health. And so even, in my ideal world, we have a community health worker who is doing these family planning consultations, if you will, in collaboration with the provider. But even then, we will still need that room and spending more time or trying to figure out where to fit that person into that schedule, or if we have multiple people who need family planning services, but we only have one community health worker. That's kind of what I'm anticipating running up against. And I'm not sure, if that's a challenge we can solve now, or something that we can just look ahead and decide as we keep going with this. But I think that we will need to actually get the providers to buy in to focus on this as well and do it during annual visits rather than every visit. And then really try to help people schedule back for a family planning visit where they can chiefly just focus on that.
I think that, Andrea, you touched on something really important about the provider buy-in, and we'll talk a little bit about that later too. So,
because we all know that's a struggle.
Yes, it can very well be. All right. So, integration of services, brings with it a lot of challenges, and so I just wanted to kind of, go through what some of them are. And I'm sure that you've already discovered your own set of challenges, as I can hear from listening to you talk. But more than just making sure that there's that workflow in place needs to happen in order to make the integration happen. So for one, the family planning visit types need to be integrated into the scheduling system, and scheduling staff need to be able to talk to clients knowledgeably about family planning visits. Providers and other staff need to be trained and comfortable providing family planning services, including IUDs and implants. The family planning sliding fee discount schedule has to be developed, approved by the board, and implemented, including training staff and making sure that that billing piece is speaking to the sliding fee scale, right? So I have both of the agencies already implemented their family planning sliding fee scale?
No.
At Hope, we
CHA
have the sliding fee. Okay. At Hope, we have the sliding fee scale almost in place. My understanding and our billing department's understanding is that they're at 100% FPL or below, then everything is free and covered by Title 10, and above that, they're based upon the slides that we use for our regular sliding fee scale. So we are just revising that. Once we get the EMR up and running, we'll be able to better track when people are coming in for family planning visits and what should and shouldn't be covered, et cetera. So it's in the process.
And Andrea, does your slide go up to 250% then? Because the two differences between, okay.
We also provide Ryan White services. So we also looked at the Ryan White slide because that goes up to 250 and above, and based it off of that. So it's incremental. We do serve people who are above that up to 400% FPL.
Great. Excellent. Yeah, because those are the two challenges for a lot of FQs, is not charging below 100% and making sure that the 201 to 250% are on the slide as well. And so that can be a bit of a challenge, I know. All right, so integration of services also involves capturing the necessary data fields for Title 10 reporting. So you might need to make some changes to your EHR to capture the required Title 10 counseling and education, such as counseling of adolescents on family involvement and resisting sexual coercion. These are two very hot topics. They always have been. They're legislative mandates, so they've always been really important to OPA. There's a very, very fine emphasis on it these days as well. So you'll want to make sure that your EHR is capturing the adolescent-specific counseling as soon as you can, because, again, that's just something that OPA will be looking very closely at. So do you have any questions about the adolescent-specific counseling pieces?
And
We
this
just
is Andrea
watched
at Hope
a webinar.
again.
Go ahead.
Sorry.
Go ahead, Kirsten. We keep talking at the same time.
Wait, I think we're thinking the same thing, so it's working out. So we actually did just watch a webinar that was very, very helpful right before this webinar that's related to the adolescents and how we go about counseling and whatnot. So that one's also going to be available through the Primary Care Association. So if anybody hasn't watched it, it was actually very valuable.
Great.
Awesome. I'm
And
gonna have to
are
look
your
that up.
EHRs, do your
Say that again?
EHRs capture, so do your EHRs have a place to capture that the client was counseled on sexual coercion, resisting sexual coercion, and family involvement?
No, that will be something that needs to actually be changed in the EMR. So in our
Great.
entire system. So there's a lot of work on that back end to do to make sure that we're hitting all of these specific points.
Yeah, and I just wanted to make sure that everyone was aware of those. So I'm glad to hear that you had that webinar today. That's great. Right, so you'll most likely need to create some fields or modify the existing fields to get your EHR FPAR ready for that, but then also to get it FPAR ready, because some of the fields in FPAR are just a little bit different, as you probably know from working with Michael to set up that process of having the data transfer. So, you know, I'm sure that your IT people are probably already writing the scripts and modifying the EHR to be able to do that. And the next thing really is about confidentiality, which is a hallmark of Title X. And I know that FQHCs provide great confidential services also, and that this idea is not new to you. And having said that, with the emphasis on family planning, you know, Title X has safeguards in place so that they go above and beyond the normal HIPAA to accommodate confidential services to teens and others who might not want EOBs or patient portals to be available to guarantors. So that's another area where, you know, working with your billing and your IT people is going to take some resources.
So Lisa, I have a question here at Hope. That was going to be what I brought up, is that for adolescents, like, we can do a lot of these things, and we'll be adding like an IPV screening and others, so it's just standardized, like the depression screening. However, we are running into, like, do we duplicate the patient account, which we don't want to do, of course. How do we flag it as confidential? Because we could flag a note as confidential, like a confidential service. But that doesn't necessarily mean that if a parent were to request access to medical records, that they would not get that, right? So how have other centers done this to build like a confidential note that's, like, I don't know, locked or password protected or something, to make sure that it doesn't get sent out to a parent if it's not supposed to be?
There have been a couple of different things. Some health centers don't allow parents access to the teens' records after a certain age. I want to say that for some it's after 13, that they just don't allow access to the teens' records, whether that be for sexual health, reproductive health, or for other health issues. And that helps with the transitioning the child into adulthood kind of thing. Others do set up kind of a parallel system. One of the ones that I'm most familiar with is an FQHC in Arizona that calls their parallel system sort of penny lane visits. And so they set up a whole different medical record, unfortunately, for that client for those visits. And the clients know to come in and ask for penny lane services. And that's kind of the code word for, I want this to be confidential, I don't want it to be billed, I don't want my parents to find out, I don't want my husband to find out. I do think that they have some way of, you know, associating back to the client's full record, but I don't know how that works.
Okay. Okay, yeah, we've been doing exploration with our IT and just kind of the back end too of our EMR, and we're just kind of running into a challenge for that. and how to do that to make it confidential. So I will suggest that. I'm not sure if there's a way to do it, but we'll see.
And which EHR is Hope using?
eClinicalWorks.
Okay. Making a note of it. I can see, I know that the folks that did Penny Lane were using NextGen at the time, and I think they've actually migrated to something else, but I'm not sure. But I know that there are many, many, many Title X agencies. NextGen and eClinicalWorks are the two most commonly used EHRs in the Title X world. So there have been lots of people that have gone before you that have figured this out. I can put out a call, to see if anyone can help us out. I don't always get responses to those, to be honest, but it's worth trying.
Okay, that would be great. Thank you.
Sure. Just making a note of it. Great. All right. So, and of course, on top of the confidential services, you'll want to make sure that you have a wide range of contraceptive options that are available, preferably on-site, stocked on-site, so that you can do same-day, long-acting, reversible contraception. So those are some of the challenges that I thought of, but I'm guessing that, each one of you has probably encountered some other challenges, and so feel free as we go through to bring those up so that we can kind of work through some of them if we can. So I also wanted to talk, as one of you mentioned, that sometimes you have providers that aren't passionate about providing the family planning services, and so in the next few slides, I just kind of want to talk about. I don't want to be preaching to the choir, but I do want to talk about some of the reasons that I'm really passionate about family planning integration and primary care services, and I think it's important because I think that some of these reasons that I'm passionate about it might be reasons that you can use to talk to the folks that are struggling with providing the services to try and get them to also be champions for family planning services. So, whenever I think about providers that are having challenges, I think back to my tenure at the Arizona Family Health Partnership, and I worked with a number of agencies as they transitioned, as I said, offering Title X services. And some of them were standalone family planning clinics that just did family planning, and other centers offered primary care services as well. And that looked different in different agencies. And one of the agencies that had been with the Arizona Family Health Partnership since the early 2000s was a federally qualified health center that for the first 15 years did what, I can't remember who suggested that this might be a model, but did that thing where if a client wanted a family planning service they mentioned that while they were at a visit, they scheduled them and basically carved out the family planning services. And you didn't mention this, but what they did at that agency was they had a specific staff that just did family planning. And so client comes in for an acute care visit and says, oh, by the way, I would really like to get some family planning services, and they would get scheduled for the family planning visit. And the provider, who has been there now, I think, for 20 years, after a certain number of years, got really frustrated with that model because she felt like she wanted to integrate into with the primary care providers because she recognized that having the clients have to come back was not that client friendly, and that integrating the care would increase client satisfaction. It would also, she felt, increase the efficiency and the continuity of care. And it does improve the health outcomes. And she also mentioned that the providers that had been trained in family planning were much more up to date as well on STD and HIV testing and treatment guidelines. And she felt like those were all really important benefits. So
I think I agree that that's the best approach. This is Annette from Community Health Alliance. Our thought process was that by the time a client is asking, it's probably something that they've been needing for a while. So, and thinking about and maybe putting it off. So we're certainly not proposing, I wasn't proposing that we carve it out. What I was proposing was that, or what I was, I think, trying to shed light on was that our Title 10 visits, there was the potential for it to take two paths, one being a different appointment and one incorporation. So yeah, I just wanted to make that
great. Yeah.
point.
And then I think part of that, it's Kirsten, I think part of that too is right now when we have someone who's coming in and we're talking about any kind of contraception, when someone does choose that IUD, we don't necessarily have that IUD in stock. So it would be paramount to have that IUD in stock, and then also, so have some on hand, so whatever that looks like with the pharmacy and how we decide to work all this out. But then also, that's going to increase the time, and the clinician might not have been ready for a procedure. So, or was that something that we planned on doing right then and there? So there, I feel like, to Annette's point, there's a lot of moving factors in that, specifically when somebody does decide on an IUD.
Absolutely. And like you said, particularly with the IUD, it can feel like it could add a lot of time onto a visit. And I will remember to send you out a resource. We have an entire toolkit on the FPNTC website and have done learning collaboratives specifically around this topic of how do you provide same-day provision of contraceptive services, regardless of the method, in a manner that doesn't disrupt the workflow, that doesn't turn that appointment into a super lengthy appointment. And again, I'm not an expert in that exactly, in that topic, but the resources that we have are fabulous. And it's things like, how do you set up the cart so that you have all of the, again, supplies that you would need for that IUD service, and how do you, how do you manage the flow of the clinic and who does what pieces. And so, again, we have a same-day access toolkit that we can point you to, and it requires some training, right? It's not like you're just going to open up this toolkit and magically you're going to be able to do, oh, look, Alicia has the toolkit right there. Maybe? I can't see it.
Yes, and actually I think you all should have it by now. There's a same-day LARC insertion. It's purple book that I provided you, but they do have an online version as well on FPNTC.
And again, it's not something that, you're going to open up that booklet and tomorrow, voila, you're going to be able to do that without any clinic flow disruption or issues. It's a process. It takes time. There's, a whole lot to learn and a whole lot to do, and that might be something that you work towards, and that is a long-term goal, but certainly not something that you're going to be able to expect to do right out the gate, if that makes sense. All right. I also just heard you say that, sometimes when you have a client that finally does talk about family planning, they've been thinking about it for a long time, and so that it's kind of a matter that might need more immediate attention. And I've heard a lot of family planning champions talk about treating family planning as sort of a code red service just for that reason. So, just as a primary care provider would never send a patient home that's complaining of a chest pain, I would hope that we would treat the risk of unintended pregnancy kind of the same way. The health and socioeconomic implications of pregnancy are significant enough and life-changing enough that I would hope that we prioritize family planning services for patients that are seeking to prevent pregnancy, even if that doesn't mean getting them their LARC that day, but maybe something that they can use in between while they're waiting to get that LARC if you're not at that place where you can do the same-day services for those. So if a client has a family planning need, we'd like to, again, not treat it as a low-level service that can wait until the next visit. And a lot of agencies that have integrated family planning into primary care sort of treat family planning the same way that they would a vital sign, meaning that just like you take blood pressure at every visit, they would touch base with their clients of reproductive age about their family planning needs at every visit.
I like that.
So, awesome. Thanks. I can also appreciate that not every clinician is going to see family planning services from this perspective, and some staff might be more cautious about integrating services than others. So if you have a clinician or clinical staff that are cautious about providing family planning services, step one is to find out why, and I think that we've already talked about some of those reasons of why. But many of us assume that if we have a resistant staff member, that there's nothing that can be done. And while we certainly don't want someone who isn't fully on board with family planning offering those services for a variety of reasons, there are tools and resources to assist in addressing some of the common concerns. So there are a lot of reasons that a staff might be hesitant, and understandably, integrating Title X comes with challenges because there's so much to do and some changes require support from upper management. It's really essential to have buy-in from leadership and have family planning champions at each of your health centers. So when selecting champions, you want to look for people that have a clear passion for family planning, because these folks can really have a powerful influence on the culture of the health center. And during the integration process, as always, recognizing good work goes a long way to keep people motivated. So even if it's just, that quick, hey, great job on getting that supply room stocked, or, setting up that cart, can really make a difference. And health center staff have to see family planning is a priority. So how do we, the people in this little virtual meeting, make the case to our staff that it is a priority, including to those who may be hesitant or have concerns? So I think that we know that in some situations you won't be able to get everybody on board, and we'll talk a little bit later about strategies for those situations. But one of the things that's really important is that staff need to be trained on family planning policies and procedures. You'll want to make time to ensure that all staff, such as the billing staff, front desk, MAs, and such, have a really solid skill set. And this can be accomplished really by taking your time and doing trainings before you implement the integration if you're still in the planning stages. Having skills checklists can help ensure that you're on track and know what still needs to be addressed. And I think you can find some of those on the FPNTC website. And also, again, I know we talked about the current workflows might need to be updated to facilitate that integration process. And of course, we've already talked about the EHR and data concerns. And I think you're beyond the point of needing that preparing your EHR. I think that you all have Michael to help you with all of that. So sometimes clinicians and other clinical staff express that they have concerns about providing family planning services. And when this happens, it's important to tease out the reasons or why they're reluctant. So is it because they're unclear about the benefits of family planning? They just don't see how it connects to the services that they provide? Do they lack family planning training, or they're not comfortable talking about family planning? Do they have ethical or religious concerns? Are they concerned that it'll take too much time, which we've heard? Or do they feel comfortable and are passionate about family planning, but they don't have the training they need to code for family planning visits? So in the next section of the session, we'll take a deeper dive into each of these challenges. But I'm wondering, are there any other challenges that I didn't list here that you also want to dive deeper into? I think we've already kind of...
I think the issue of parental consent, particularly with providers that might have teenage kids, I think that could be an issue.
So are you talking about when a teen comes in with their parent for a visit, or are you talking about a teen coming in by themselves? Yeah. So in between working with family planning, I worked with the Arizona Family Health Partnership twice, and in between I went to the Arizona Department of Health Services and worked in children with special health care needs. And I love the way in children with special health care needs, they do such a good job of transitioning the children to adulthood, or the teens to adulthood. And sometimes that process starts as early as 9 or 10 years old. And, it was really intriguing to me that they do this for children with special health care needs. But when I would bring my kid into the health center, even though he kind of did have special needs, no one ever tried to work with him to transition him into adulthood. And so
I know. I just went in with my 18-year-old son to get his warts burned off. And they didn't even ask if he wanted me to come in or not. Yeah, I just went in.
Yeah, so I think that there's a lot that we can learn from children with special health care needs world in terms of maybe implementing, not so that we can, not even like, starting before it becomes, oh, your child is 16 and it looks like they might be dating, so I'm going to ask you to step out of the room, right? But starting that process earlier on and talking to the parents at developmentally appropriate stages about, we're going to start working with you to transition your child, your teen, your adolescent into being able to manage their own health care. So at some visits, with your permission, I'm going to ask that you leave the room so that I can have a conversation with John or Jane. And that's the conversation that I'm going to have is going to be confidential between us. And, you're going to want to teach him how to use his health insurance card. And, it can be part of a bigger, broader conversation so that it doesn't, again, end up being this thing that is so scary and clearly focused on just sexuality and reproductive health.
This is Andrea again at Hope, and something that I'm proposing that we implement within the next year for our adolescents is one, having like a sign on the doors leading into the clinic saying like, hey, starting January 1st, 2020, if your child's over the age of 12, we're going to take them back before you. You can expect to be taken back 5 to 10 minutes afterward. And this is going to allow us to do a youth risk reduction screening tool that their parents don't need to be present for. And then also have the provider have a time before the parent even enters the room to address some of those things that show up on the risk reduction tool, or to address any of the other concerns that adolescent might bring up. So that's something that I think we're going to bypass some of that conflict from parents, because it'll just be, we'll have that conversation and it'll be on the sign of, like when they're 12, this is why we want them to, become more independent. So hopefully that will give us that.
That's pretty cool.
ability.
Aren't you guys going to put that in your new patient materials too?
Mm-hmm. Yeah, so all of the intake, if it gets approved by leadership. The other thing is that what we're trying to do is have the ability to, like Lisa was talking about earlier, if you have like 2 patient charts for one patient, one being confidential, one being open to their parents, then the provider having the ability to pull up both charts during the same visit. And so when they're there with that adolescent, if it turns out that it needs to be a confidential conversation, they can just pull up that confidential chart. So that's, in an ideal world, that's what's going to happen. So those are the conversations we're having here. Whether or not that happens in the first year, I don't know. I don't think it's going to happen that quickly, but it's something that, ideally that's what it'll look like. And then when they bring that parent back into that room, they can close that confidential chart, and then they can go forward with their annual well check.
And this is Kirsten from CHA. Oh, just really quick, I don't want to forget about the population of teens that will actually seek out services without their parents. So, and making them feel comfortable in the waiting room and, not singling them out. So in some of our smaller clinics, one being, out in, let it be Sparks, or even if we go to Sun Valley, there's some, teens that definitely could utilize family planning services and contraception, and they would likely go without their parent. So just also being, making sure that we make those kids comfortable at the same time, because it's daunting for them, especially when they're young.
Absolutely.
Yeah, that's true.
So,
good point.
2 things. I just wanted to say that I really love the approach in terms of like a sign in the waiting room and making it so that this isn't something that we're singling your kid out for, right? This is something we do for all of our clients. And I think that whenever we couch things in that way, this is something we do for all of our clients, it can really help smooth things over, right? And in terms
Andrea,
of,
why did you guys pick 12?
So legally, that's the age when they should start having private conversations with their provider. When they legally have a right to confidential conversations with their provider. Yeah. The other thing that I would suggest if you're looking to improve your adolescent health initiatives, there is a program through the University of Michigan called the Adolescent Health Initiative, or AHI, and they provide a tool called Adolescent Centered Environments and Assessment Process, and it's about a 1-year process that they kind of walk you through and give you work plans and best practices and things like that to improve like your waiting area or how long the teen is waiting for, with the assumption that these teens are alone. And so that's something that we've been doing here. We have a teen table that I jokingly call the sex table because we put all our sexual health information up there. We'll be doing like teen artwork from some of our local high schools as well, and also educating our providers on a whole bunch of, like nonverbal communication or like don't try to sound cool. They don't like that. It's not cool. It's not funny. Like how to relate to them when you feel like you're trying a little too hard or you don't know how, right? So things like that. They also have Spark trainings that are about 10 to 15 minute staff trainings, and that's through the Adolescent Health Initiative as well. So those are really helpful when you don't have very much time with your staff. And I want to adopt some of those into our practice here at Hopes, and then even perhaps with Title 10, try to replicate that when we only have 10 to 15 minutes with staff, like some of those coffee break trainings that I saw on the FPNTC website. So
you guys are all love the reference. And I love the reference to the FPNTC website. Thank you for the plug.
Yes. You're welcome. It's helpful.
That all sounds wonderful. So in those materials, Andrea, I'm wondering if there is ever a recommendation that when you're in a small community, I've seen this in some small health centers, not every health center can do this because of space allocation issues, but I can remember being in some rural communities where they would actually have instructions to the teens to kind of come in a back door if they were worried about being seen in the clinic. And, I don't know how small your small communities are. I don't know if it's that small that they have to worry about that kind of thing, but I've heard about, situations where they make it clear for teens that there are ways to come into the health center so that they won't be observed, if that's possible.
Yeah, I'll have to take that into consideration because ours is just totally open. Yeah, I guess it's something I can talk to our adolescent team about.
Yeah, and I don't know if it's necessary or even feasible, but it's just one trick that I heard. So anyhow, so were there any other questions about any of that before we move on to me trying to solve family planning? Excellent. So, when I think about some of the staff that are resistant and they're thinking that, and I don't mean to be using the word resistant disparagingly because the barriers and the challenges are, they're real. They're concrete. There are things that make it really hard to add yet one more service into this. But some of the things that I think can be a little bit motivating are things like sharing outcomes data with staff. I know that most of us who are in public health are there because we want to improve the lives of the clients that we serve. And in 2017, the most recent data that I have for Nevada is 2017, but Title 10 contraceptive services in Nevada in 2017 resulted in over 2,000 unintended pregnancies being prevented, 1,000 unplanned births being prevented, 700 averted abortions, and 420 miscarriages that were prevented. And approximately 270 of the unintended pregnancies, would have resulted in preterm or low birth weight infants. And so, the work that you're doing, and every time that you can prevent another unintended pregnancy is a huge deal to be, celebrated, I think, and again, can be really motivating. In addition to averting unplanned pregnancies, the services that the Title 10 folks are providing impact other areas of health, right? So again, this is 2017 data that the impact of chlamydia screening for women 24 years and younger at Title 10 clinics in Nevada was that 80 chlamydia cases were prevented and 10 cases of pelvic inflammatory disease. And as more and more Title 10 services are being provided, you'll also end up seeing, cases of tubal pregnancies being prevented and PI, well, we already have the PID being prevented, but and the other thing, and so I'll just move on to the next slide, sorry. The other thing that might be motivating to providers is that they can be inspired by knowing that integrating quality family planning services can also save money. So nationally, for every dollar spent on family planning, $7 is saved on just Medicaid costs alone. And the net cost savings after accounting for the cost of providing the Title X services in Nevada in 2017 was over $6.5 million. Again, just from the contraceptive services and chlamydia screening in females 24 and younger. And the closer you bring this information home, the more meaningful it is. So the Guttmacher Institute, the way that I came up with all this is that the Guttmacher Institute has a great tool that you can use to demonstrate how much money your agency has saved by providing family planning services. And again, for this presentation, I used the Nevada FPAR data, the Family Planning Annual Report, which is like your UDS data. But I wasn't able to include a lot of the services that when you use the tool, you'll be able to use, which will show even greater savings because you'll have access to not just the contraceptive services and the chlamydia tests, but also gonorrhea tests, HIV tests, HPV vaccines, and PAP tests that you can put into this calculator that will show you how your agency has saved money and prevented pregnancies and chlamydia and all that good stuff. So I love that calculator. I can't recommend it enough. And I think it's a really fun thing to show staff for your, for what your agency is doing. So another issue that may make providers reluctant to provide family planning services is not feeling knowledgeable or comfortable with the topic. And in terms of general family planning and reproductive health knowledge, there are a lot of great resources out there. So for most of these trainings, you shouldn't need to reinvent the wheel. And while primary care clinicians don't need to know everything about family planning, they should have a foundational understanding. So integration does require that your agency staff train on the specifics of your family planning program. In general, staff are going to need to know which family planning services you will or do offer. Are you adding large services? And if so, how do these appointment slots differ, if at all, from other appointments? How are exam rooms stocked differently if you're adding same-day large visits? How will the Title X sliding fee schedule be implemented? How is billing handled for clients requesting confidential services? And finally, staff are going to need to be trained on your agency's family planning policies and procedures. So it's a lot. So when providing training, I would recommend that you don't jump the gun, but that, the clinician that I was talking about who was really passionate about going from a standalone clinic into a family planning clinic, I spent a lot of time talking to her. And she kept coming back over and over again to the training of staff issue, and that, making sure that you have plenty of opportunity for role playing and asking questions, she felt was really key to making that integration happen. I think that she was surprised at how much kind of support folks needed in terms of the role playing and, being presented the material over and over again. I think sometimes we're asking some folks to do very sophisticated work in counseling around, offering client-centered counseling, and that it really does require providing a lot of support around that. So including all staff in the training from front desk and MAs and clinicians and billing is essential, in part so that, again, they gain that confidence and competence, but also so that they feel a part of the process and that they feel like they can, just be a part of the process. So in order to assist you with the training needs, the Office of Population Affairs actually funds 2 training centers. There's the Family Planning National Training Center, which is the training center that I work for, and then there's also a National Clinical Training Center for Family Planning, which is a mouthful. It's the NCTCFP, even the acronym to me is a mouthful, and they are specifically charged with training the clinical staff. So if you have providers that need training on LARC insertion, then the National Clinical Training Center for Family Planning is your go-to place. You can get to either of the websites from each other. We have links back and forth to each other. Both of the training centers provide free training, technical assistance, and resources. And so between the two of us, we just have, I think, a really rich, sometimes overwhelming amount of materials for folks. So we have on the FTNTC website, we have a number of different toolkits. And one of the first ones that you might want to take a look at are the training essentials, which is pretty new. I don't think it's been up there for that very long. This toolkit is designed specifically for grantees, such as the Nevada PCA, but I'm listing it here because I think it's also really helpful for subrecipients such as yourself. And this is training essentials. This is the training essentials landing page. And from here, you'd be able to get links so that you can sign up for the Joint Training Center's newsletters and training announcements. So if you haven't signed up for our newsletter, I highly encourage you to do that. You can also create an account on the FTNTC website where you can save resources for later, register for and track and share your completed trainings, and also contact the training centers from this landing page if you have any questions for either us or the Clinical Training Center. So there's a little blurb on there about the liaisons, and just kind of to let you know, I am the liaison for all of Region 3 of the U.S. Public Health Service, plus a couple of Region 9 folks. And so really I am the liaison for the Nevada PCA, and so I'm available to them for, technical assistance. And so if you need assistance, you can go through them to get to me if you, need kind of a deeper dive. So the Training Essentials Toolkit that we were just looking at has links to a wide variety of resources that can be used in any order. For example, there are resources for an overview of the program requirements, clinical guidelines, and required training topics. And the link is on the slide, the hyperlink. Another great toolkit on the FTNTC website is Providing Quality Family Planning Services Toolkit, and this one covers 8 different topics with multiple resources under each of the topics. And you can see that the topics closely align with the core family planning services that were defined in the QFP on an earlier slide. And the resources in this toolkit can be used in any order, again, depending on your needs and priorities. The trainings and materials are organized into categories that, again, align with QFP. And these are fantastic resources for helping your staff, again, gain that confidence and competence in providing the family planning-related counseling and education for those core services. So another way that you can kind of figure out what training you might want a particular staff person in a particular role to look at is that we have this this tool that either you as an individual or your training manager might want to use to ensure that you're assigning the appropriate training to the staff. And so the way that this works is, sorry it's a little bit small, but first on the left-hand side, I'm pointing, and you can't see what I'm pointing to, I'm so sorry. But there's 3 drop-down boxes. And the first one is where you select out the professional role, and you can choose from billing or financial assistance. And so for the question about where to find resources to help with the connecting the billing and the confidential billing piece and how that works, if you go in and select out billing here and financial assistance, you might be able to find something that way. So the different roles, though, are billing and financial assistance, clinical provider and nurse, front desk and receptionist, health educator / counselor, medical assistant, and manager, administrator, or center coordinator. So then the middle drop down is after you select your role, you'll select the type of resource that you're looking for. And you can choose from things like increasing knowledge, building skill, support implementation, or conduct training. And then finally, on the right-hand side of the screen, there's a drop down for the kind of resources for the topic that you're looking at. And there are roughly 20 topics to choose from, ranging from training on providing services related to basic infertility, to third-party billing resources, providing contraceptive services, human trafficking, providing services to adolescents, and much, much more. So in this example on the slide, I selected out the role of medical assistant to find contraceptive services skills building resources. And you can see that it came up with 4 different resources that were found, including a birth control methods option chart, an e-learning course on explaining contraception for healthcare providers, and a toolkit on increasing access to contraception. So I didn't do a screenshot of another way that you can go in and get resources, but there is also, when you go to the landing page, you can look under training. Like one of the things on the top is, I think, training packages, and there you should be able to go in and find the items that are specific to the billing, and might be able to, find what you're looking for there. But there's a number of different topics, and you can drill down that way as well. So before I move on, does anyone have any questions about the resources on the website, or have you been looking for something specific that you got frustrated and weren't able to find, and maybe I can look into it and send you some resources?
So for all the mandatory training, so we do have a list that was provided by Alicia, mandatory trainings. And so I kind of took it upon myself to go through. I made an Excel spreadsheet on what the mandatory trainings were. And some of them might not necessarily match up with exactly what it says, like from the PCA and then what it is, the Family Planning Training Center. So I'm not exactly sure, and I can send this to you guys. Like, I just want to make sure I'm taking all the right ones as well, because I'm checking them off a list here because I've been on this a lot. So I'm like, I want to make sure that I'm understanding all of this other stuff. So some of it has been hard for me to find exactly what it is we're supposed to be looking into. Does that make sense?
It does, absolutely. And I think that some of the things that are required are kind of wrapped up into, for example, the Title 10 orientation probably has maybe the first 3 things on the list of volunteer services have to be voluntary. They have to be provided without, any prerequisite, saying that, that you've got what's it called, not geographical, but that you're a resident or whatever. So a lot of what's required might be wrapped up into the Title 10 orientation. So I can absolutely take a look at that and see if I can pinpoint where you might be able to find some of the training on the
the ones that I'm not.
Yeah.
Perfect.
So if you send that to Alicia, then she can send it on to me.
That would be awesome.
Lisa,
thank you very much.
Lisa, this is Alicia. Some of those, I think what Kirsten's probably talking about is some of them are just like acknowledgments, not necessarily a training, or like maybe the staff has to acknowledge that services can be coerced or endeavor to coerce. Yeah, and so in those instances, it may not actually be a training, but maybe if maybe there's like a statement or something that they could have all their staff sign acknowledging those certain requirements.
Yes, the FPNPC has not created that acknowledgement statement, but it's easy enough to do, to just create a form that says, and some agencies have people fill it out annually that says, I acknowledge that if I coerce or endeavor to coerce a client to pick up a particular method or get an abortion or get sterilized, that I could be subject to prosecution. I attest to, blah, blah, like there's 3 things. And I've seen agencies have them, and they're yeah. But you're right, sometimes people include that on their training. And I think that OPA wants to make sure that, that they're trained in that, and so those are covered also in that Title 10 orientation. But that's separate from needing to have the access to.
So this is Andrea at Hopes. Alicia, in regards to that training list that you gave us, could we just show that Title 10 orientation or the first half of it and then check off 3 of those things? Because I am having I'm not going to say a nightmare, but it's almost a nightmare trying to get all these trainings scheduled for all of the required staff. And that would just simplify it a lot if we could do that first like half hour.
Yes. As long as they've been told and they can acknowledge, I mean, that's all it really is that they know those requirements.
Great, thank you.
Yeah, some of those training requirements are so short that you're not going to create a separate training on it, because it's basically, saying, hey, if you do this, you're going to be subject to prosecution and the training, right? So that's why they're all sort of wrapped up into that Title X orientation. Are there any other resources that you've been looking for in terms of training or workflows or anything else? All right.
Lisa, can we talk to you outside of this call if we have questions or anything later on? Because I am going to have to hang up here in about 15 minutes because I am teaching this afternoon at the Boys and Girls Club. But I do want to continue some of these conversations.
Absolutely. I think that my contact information is at the end of the slides, and if not, I'll include it.
Excellent. Thank you.
Sure. So another challenge that Title X funded health centers sometimes face are staff who have ethical or religious concerns. And, sometimes staff are fine with offering some family planning services, but not others. And we've all probably had certain situations that stick in our minds at work that we'll just always remember. And for me, one of those was the meeting that I had with a clinic manager and a clinician in a very, very rural part of Arizona. And I remember the three of us sitting in this waiting room, and the clinician sat back in his chair, and I would demonstrate, except you won't be able to see me. He sat back in his chair, and he propped his feet up on another chair and folded his arms. And it was very serious looking. And this man, totally wasn't going to budge. He was very adamant that he was not okay with providing IUDs, nor was he okay with doing options counseling. And so, when I looked at his posture, I realized I also didn't want him doing these things, right? That's not the person that you want providing your teenager with those very sensitive services, right? Or anyone with those services. So I also knew at the same time that he was in this really rural community where there really weren't a lot of other resources or places for people to go. And so I wanted to try and figure out how we could make sure the clients were getting their needs met. Luckily, this rural community had another OBGYN in private practice, and that Title X subrecipient was able to put a contract in place with that other provider so that the other OBGYN would provide the IUDs. It was more than a referral arrangement. The subrecipient actually provided the IUDs, and the client just went there for the insertion. And then in terms of the options counseling, we kind of got lucky in that they were hiring for an MA position, and so we made sure that during that hiring process, they hired someone that was comfortable with the idea of doing options counseling. That MA was sent for counseling, for training on doing options counseling, and then that subrecipient was able to provide at that rural center the full scope of services. So, when you have these situations, which will occur, it happens, I think that there are workarounds. Sometimes they require some creative thinking. So I'm wondering if you all have folks that have expressed concerns and that aren't thrilled about providing services.
At Hopes, all of our providers are actually very excited about this. They're not excited about any extra work that they might have to do, but they're excited about providing this. We do have some pediatricians who are concerned that IUDs might be, in some cases, contraindicated for teenage girls. Those are things that we can do education on. And otherwise, there's a lot of enthusiasm. It's just the extra work that comes with it until we find a good workflow that people are really hesitant about.
And that's a good point that a lot of the pediatricians are still going to be being, because it wasn't until recently, right, that folks really came on board with IUDs are a great method for adolescents who want them, right? And so that's a bit of a paradigm shift for a lot of the clinicians that have been around.
Yeah, and we've really wanted to do IUDs for a long time, so it's only recently that we've gotten that on board. But at least I think about half of our providers are able to do insertion. And I think all of them are good to start counseling for that. So they've definitely been recommending it. So it's good. We like it.
Awesome.
I think here at CHA, and this is Kirsten, that we'll definitely second what Andrea said, is people seem really excited about, Title X coming and having funding to, work on, family planning and whatnot. I think one of the excitements that we actually had is when people found out there was, some basic infertility talks. So that was something that nobody really had even thought about, but that became something that was exciting. And I think one of the challenges that was brought to my attention was around, so we also have WIC here, and so women who are pregnant, still breastfeeding, and that would be something of, the contraindications of providing some sort of hormonal contraceptive method. And so we had to talk about how we would like to go about doing counseling women who, of course, they're not wanting to get pregnant right away. They are still breastfeeding. And since that could, any of the hormones can be passed to the infant through breast milk, that was a concern that she had. So we talked about IUDs and, non-hormonal IUDs, if that was the Paragard specifically, or even the possibility of something basic like a sponge during that time. So that would be something that would be a little bit better for that specific population. So something I hadn't even really thought of was that the new mothers still breastfeeding population.
Great. Well, and I'm glad to hear that it doesn't sound like either of the agencies are having that particular provider who is not ethically on board with it, because that can it can be a little disruptive for the culture of the clinic. And so I'm glad that you all aren't experiencing that, and hope you continue to not experience that. And if you do end up with that provider, I just kind of basically suggest kind of doing what we did here in figuring out workarounds and not making providers that aren't comfortable providing the services provide the services, because I don't think it's good for anyone. All right. So, I think we already talked a lot about the time pressures that clinical staff feel, and that they're real, and that, some of the things that you can do to mitigate those and make things go a little bit more smoothly are to ensure that the examiners are stocked with everything that you'll need. And again, that same-day access toolkit can really help with some of those tips around that. Assessing your clinic flow, the FPNPC has a clinic flow assessment that has some great tips on our website. We also have this really short clinic flow efficiency cartoon that I love. It's like a 2-minute cartoon. So I highly recommend that one. And again, ensuring that all staff are working at the time of their license or scope, and creating or adopting workflows that can improve efficiency, reduce waste, and decrease the time. And again, we also have a clinic efficiency toolkit. So that might be something that you can look at in terms of looking where there might be some time that can be better used. So I also highly recommend the clinic efficiency toolkit, which I did not list here. One way to streamline the family planning conversation is to ask the one key question or something similar. And if your agency uses an intake guide, I would consider adding the one key question or the equivalent to that guide. And this guide shows what should be addressed, when it should be addressed, and where to document it in the EHR, which is really nice, because I have been to many, many, many agencies where it's being done, but it's being documented all over the place. And so trying to quantify how much you're doing it can be problematic. And so I really like that this intake guide has that EHR location for where to do the documentation. So I borrowed this from an agency that uses this intake guide, and you can see here that this agency asks do you think you might want to have children someday? They ask it annually, as was suggested by, I'm sorry that I don't recognize the names with the voices yet, was suggested that that's one way that you do it, is to ask annually, and when the client has had a change in circumstances. And that in that additional information column, staff are given the guidance that this should be asked of all male and female clients of respective age, and that it should be documented again in the social history section of the EHR. So I didn't want to overwhelm you with a bunch of resources, so I prioritized 2 other resources to share with you during this session. But I again encourage you all to go to the spncc.org to look for other resources to facilitate integration of Title X into primary care. The first resource that's listed on the left-hand side of the screen is a case study on Title X and F2HC integration from the Family Planning National and Reproductive Health Association, or NIFRA. And it's split into 2 different parts. And the first part is really about making decisions about what kind of relationship to have with your grantee. And I think that, you're past that. And so really it would be the second part of the sustainability solutions that would be interesting to you, because that contains some case studies from 3 different agencies that identified kind of common themes and models and how they addressed some of those common challenges. Another common challenge that I find is that staff sometimes don't have the skills to code for family planning services. And so the second resource on this slide is for the first module of a 3-part e-learning course for staff who code, and can be used with staff that have absolutely no prior medical coding experience for the first module. And then it gets progressively more sophisticated, so that the third module in the series is intended for experienced coding clinical staff who want to test their coding skills by going through some reproductive health examples of complex cases. So, in summary, integration of family planning into primary care increases client satisfaction and improves health outcomes. Including all staff in the transition process might require some work up front, but the staff will appreciate being in the know and will be more likely to embrace the family planning as a code red. There are lots of resources available, so please don't reinvent the wheel. I'm guessing that you all already have enough to do. And finally, I know I've thrown a lot at you, but I also want to make sure that we have plenty of time for any more questions or for you to bring up any other challenges that you're facing that we didn't already discuss.
So this is Kirsten again. When we talk about the workflow process, specifically like what questions, so we're going to have to change our intake forms. We're going to have to change a lot of things that we already have kind of existing to get these questions out there so we can figure out the family planning component. So when, a conversation we were having is what should be asked then at intake, and then what can be asked with the MAs, what can be asked, to more or less move the load, the burden of all of this across the entire organization versus here you go, MAs, you're going to do it all.
Right. So I don't have a quick answer for you on that one. In part, I think that it is really agency specific, but I also think that having the opportunity to talk to other F2HCs about what they've done can be really beneficial. And so I would encourage you to do things like go to the National Family Planning and Reproductive Health Association meeting, which has at every meeting, which are usually 2 to 3 days, they usually dedicate an hour or 2 for the F2HCs to have an affinity group to come together and meet where they can ask each other exactly those kinds of questions. And I think that, you have an opportunity a little bit within Nevada to ask some of your sister agencies those kinds of things. And it may be that the clinic efficiency stuff might have some of those answers in there, but I don't have the answer off the top of my head.
That's okay. I think so. Do we know when that meeting is? I'm sure you do, Lisa.
Well, I want to say the next one might be October. We just had one. Do you remember what the next one is, Alicia?
The regional one? The NIFRA one?
Yeah.
Regional?
Yeah, the regional.
I haven't heard anything yet.
I plan on reaching it. I was planning on reaching out to Georgia PCA because they're involved with their F2HCs and Title 10 integration. I'm gonna try to see if we can do something where we can get on a kind of a call, and that way our F2HCs can kind of talk through some of these things.
Very cool.
Or
if anybody, you guys even have a list of like people we can that you know that would be willing to kind of, you know, spend 30 minutes with me on the phone or something. I think that would be really useful if you guys have like a contact or something.
From other F2HCs?
Yeah.
Yes, yes, and also from the PCAs as well. The Iowa PCA
cool.
and the Georgia PCA both have been involved with their F2HCs and have helped them integrate Title 10. So I can give you some names and numbers, but I'd also like to do it as like a group so that all the other F2HCs that are part of this program can ask questions as well. But we can certainly set something up like that.
Whatever y'all want to do works for me. That was my Georgia talk there. Whatever y'all want to do.
You'll get along with him just fine. Any other questions? If not, then I think Andrea is very. Sorry?
I just want to say thank you so much for your time and insight on this. I really appreciate it.
Oh, you're welcome. I'm glad to be able to do it. And my contact information, it turns out, is on the slide right there. And I know this is going to make you all very sad on a Friday afternoon that we're going to end a little bit early, but I hope you'll be able to live with that.
Thank you, Lisa. Really appreciate it.
My pleasure.
Thank you.
Thank you, Lisa. And then we'll be following up on some of the items and resources that Lisa mentioned, and then we'll also email everybody the slides so you can click on those links.
All right. Great getting to hear you all.
Thank you very much.
All right.
All right. Have a good weekend.
Bye-bye.
Bye.